Welcome, everyone. Thank you for attending our webinar tonight. I'm Carrie Mendoza. I'm an emergency medicine physician and part of Neutral Neighbors. I'm here with Ted Dabrowski, and we're going to talk about making sense of the local COVID numbers and school reopenings. I'm going to start off and just talk a little bit about my experience as an emergency medicine physician, working, in ERs on the south side as well as up in Kenosha, Wisconsin, and what I've been seeing and just updating that. Early on, just to summarize, the first phase in, February, March, April was really about flattening the curve. We weren't sure the volume of patients we were going to see, and the concern was preparedness around a surge. And that, resulted in closing elective procedures. The emergency department had various plans in place, including putting tents out in the parking lot. And we actually really didn't see a big surge at that time. And our ER volumes did go down about 35%, but we never really had, thank God, a surge that we couldn't handle. We didn't really use that extra capacity. Then we entered phase two, which is really when the economy reopened and there was more of just general community spread through the summer and early fall, and our hospitals reopened with full capacity, resuming elective procedures. Our emergency department volumes returned close to 90% of what we had, and we had fewer hospital COVID admissions, a lot of patients that had COVID but were fine to discharge home. And then now we kind of break this into a third phase where we've had accelerated community spread. We definitely have increased COVID admissions, but it's less than the peak we had in the spring. And we have many more patients that are admitted to the regular floor versus the ICU, and our mortality rate has declined significantly. So the hospital's really handled the increased surge and has been able to maintain our full services. And I think a lot of that is related to just the lessons we learned at the beginning. The treatments have improved greatly, and a lot around how the medical centers handled staffing. So we've had no need for overflow tents or emergency workers going across state lines. So in terms of the metrics that really matter the most, it is a continuation of what we learned at the beginning. We really look at the high risk groups, so the elderly, folks with comorbidities, keeping a close eye, obviously, on hospitalizations and the capacity, and then the mortality rate. As I mentioned before, our treatments are really effective now. We give people steroids early. There's a host of different medications that are available that have really been quite effective. And the healthcare workforce really hasn't had transmission in its own community. The metrics we look at less is really the low risk groups, because it just is out there in the community. So we know that a lot of folks have it. They come into the emergency department with mild symptoms, but they're discharged home with standard precautions. So in terms of, how the workforce is managed, you just to sort of shed light on what goes on in a medical center versus other, areas, other workforce environments. There's no routine testing of the medical workforce if you don't have symptoms. If you are symptomatic, or if there was a high risk exposure where you weren't wearing your mask for some reason, but everyone is required to wear one, but if there's some unusual circumstance, then there's testing. And then in terms of returning to work, the medical centers follow the CDC guidelines. It's really based on symptom management and symptom monitoring, not repeat testing to prove a negative. And then also, our emergency department isn't redesigned. We all sit, close together. We're in and out of rooms. There is, cleaning procedures, but with masking, hand washing, and the basic things we do, there hasn't been there hasn't really been any transmission in our emergency department among staff. And so just, to sort of put context on that with schools, obviously, my feeling is that they're essential business. And if the hospitals, Amazon, grocery stores, et cetera, can function safely, I feel schools can kind of take our best practices and move forward, in that way. And so just, we've learned so much with this pandemic and in the hospital, how we do things, and more restrictions or testing protocols doesn't translate into less transmission, or mean that you necessarily can't, function properly. So, and just to kind of leave everyone with a thought from my toxicology fellowship, which is really based on the idea that, any type of intervention, any type of medicine can be toxic if it's at the wrong dose. And so when we think about how we're applying, strategies to what we're doing, we have to think, what's the therapeutic window that you have the desired effect you want, but you don't overdo it so you're having negative or poisonous effects. And one thing we've been seeing in the emergency department is, increase in mental health visits, and that was captured by a recent report through the CDC, that teen mental health visits are up 31% since April. And what we're not seeing is kids in the ER with COVID at all. Since this started for us last February, I've seen maybe two preteens that had very mild symptoms out of hundreds of adults. So yeah, so everything is going well at the front lines. We're tired, but we feel that things are being managed very well in the hospital, and we're really thankful that the mortality rate is really coming down. So with that update, I'm going to kick it over to Ted, who is going to you got
share
it there,
my
Ted?
screen.
Yep. Okay.
Thanks everybody for joining. Thank you, Carrie, for doing that. And what Carrie was talking about is important because here we are. A big part of our talk is about schools and COVID in general, what's happening in the state. But with the frontline people at the hospitals, it's great what they do. They of course are there, and they've been doing it for months, and I think they're proven that it can work. They have a lot of the precautions. Maybe they're organized for it, they're prepared for it, but they show it can work. And so it's good lessons learned for when we talk about what we're trying to do at schools, in particular New Trier. So let me just do a little bit of talking about COVID at the state level. And it's important. One thing I want to start with, this thing is we all know, as we've talked about opening New Trier more, it's become heavily politicized, and lots of emotions, lots of let's call it mudslinging going both ways, and it's painful, right? But I think we have to realize that this is, I don't care what side you're on. This is a nasty virus, and anybody who says it's not, well, okay. We've seen, the massive number of deaths we're having. We've seen the cases rise a lot. We've seen the hospitalizations rise, and so it's something that we have to reckon with, and we have to respect it. That said, it's always really good to just be, look at the facts with a cold, sober approach to it, because the data tells you a lot of things that otherwise your emotions would take over. So that's what we try to do. That's what I try to do all the time as I do this, and think about what it means for policy at the state level, for opening up businesses, for opening up schools, and making sure that that our economy functions while we figure out how to manage this monster virus. So let me just start by saying one thing. You guys will all remember back in May and June what a crisis that was, right? We're having 100 and something deaths a day at its peak. It was scary. Nobody knew what was going on. We were shutting down, hoping that things would get under control. And eventually they did, right? And we moved into that if you look at this graphic here, this mid-June early July period where the number of cases really dropped off. And then they rose slightly, and then they rose slightly, and then suddenly in whatever that is, early October, we've been on a ride where cases have gone up 6 times what they were back at our old peak. And that should be really scary. And this is what happened. The fear that came on, as the news and others started talking about the case increases. It was just a massive case increase. And so if we had had the hospitalization and deaths that go with a 6 times increase in cases, we'd be having a very different discussion today about the true risks of this virus. But we've learned a lot through this period. And so let me share that with you. So even though cases are up 6 times, what you'll see is that hospitalizations are only up 25%. And as bad as that is, right? It's bad. We're over our previous peak by 25%, but we're not 6 times higher, right? If we had 6 times higher hospitalizations, we'd be at 30,000 hospitalizations, not 6,000. And so, we got to take the good news with that. What does that mean? And why is that? Why don't we have 6 times the number of hospitalizations? And the big part of that is, our treatments are better. We have, of course, many younger cases. There's a lot of the 29 to 49, 59 that are the cases now where early in the crisis, there's a lot of the older people who, of course, were in the hospitals because they're coming in sick. Now we're doing lots of testing and finding people out there, some of them who become hospitalized. But take that as good news, and that we're doing much better managing cases. And here's the really good news. As bad as things are, and please don't let me, I'm not trying to diminish the death situation. We've spiked up to over 100 deaths a day these days on average. But the good news is, despite cases being up 6 times, our death count is pretty much flat with the last crisis. And again, that's coming from better treatments. And of course, many of the cases are asymptomatic. Many of them are, people are sick, but not so sick. We get them out of the hospitals faster, even though the state doesn't give us any of that information. Other states give us, who's coming into the hospital, who's leaving. They give us what the ages of the people being hospitalized are. If you look at Florida data, for example, they give you that every single day, who's hospitalized and who the cases are. We don't get any of that in Illinois, so we're kind of blind here. But this death is good news. And if you think about it, when you have massive number of cases and the deaths aren't up at all in relative terms to the last spike, that means that the fatality rate has collapsed, or at least the known fatality rate, or said it the other way, the survivability rate has really improved. And that's great news too. So this COVID is so bad right now, and it is. I'm not saying it's not, but if it's so bad, how do we understand it then? Well, I was really perplexed. This is probably, what is this, November 19th, right? So about 2 weeks ago. I was really perplexed because that's the day that the Governor Pritzker announced there were 168 deaths. And I said, wow, geez, who is that? It was the biggest number since the May-June peak. And so I went into the numbers and I said, who's dying? Is this starting to hit all the people that were, we know it's been hitting the elderly and the infirm. Is it now starting to hit the young people, and what was amazing about that biggest day since June, July was that, what is this, 90, I think it's 93% of all deaths were 60 and older. And just 3 of the deaths were under the age of 50. And so that raised all the questions for me of like, wow, okay, we've got a real problem, but where is this problem? How does it relate a lot to what we're trying to do at New Trier and opening schools? It's like, how should we use this information and understand it? And so you see this massive, massive problem with elderly. 94 people were over the age of 80. That is a phenomenal number. And then when you add the 39 over 70, you're saying this has to be a retirement home problem. And lo and behold, half of all deaths in Illinois have come from retirement homes. And it was a big problem. Is if you look at this graphic back, this is by week. So these numbers here that you see are the share of deaths that week that were happening in retirement homes or related to retirement homes. 2/3, 3/4. It was a big problem. And we were led to believe that this problem was solved. It's been out of control across the country. Illinois was not spared. And we were led to believe that this problem was solved. But if you look now, there's weeks where we have, close to 60% of deaths still coming from retirement homes. And that's a real problem that still has yet to be fixed and has yet to be answered to. If you look at the data, I'm going to skip this chart and just look. Places like DuPage County that have had, nearly 700 deaths. Well, there 500 of their deaths have come linked to retirement homes. Lake 65%. Look at LaSalle County 81%. Coles 84%. This is where a lot of the problems happening. And so the reason I bring up all this is because I wanted to understand whether our thoughts of opening schools was a bad idea, or were these deaths unrelated to schools. And that's what we're finding, is that there really are back at the point where we haven't figured out how to stop these deaths in retirement homes. And not only that, what's critical to understanding COVID is that it's not just elderly, but it's also those with underlying conditions, pre-existing conditions. And of course, there's a massive correlation between age and underlying conditions, right? Obviously, the older you are, the more hypertension risk you have. The older you are, the more health problems you have, whether it's diabetes or something else. And what you see here is that in Illinois, this is only Cook County. Illinois does not release its comorbidity data. Nobody releases comorbidity data. Cook County, by chance, happens to report all deaths and the reasons for those deaths. So at WirePoints, we've gone in and gotten the data. Anybody can get it if you know how to use Excel. And you can go get it and analyze the deaths and which deaths come with underlying conditions. And so in Cook County, as of November 23rd, 2020, there were nearly 6,000 deaths, and 5,400 of them, or 91%, were people that had some comorbidity, typically diabetes, hypertension is the big one, obesity is a big one, other kinds of cardiac arrest, a lot of people with cancer who have are immunocompromised, compromised, are at risk. So again, what we're finding is that it's the problem of the elderly and the problem of those who have some kind of underlying condition. And there's been 8 deaths under the age of 20 in the entire state of Illinois since the beginning of the pandemic. And here's an example. We don't have information for 3 of those deaths because they didn't happen in Cook County. We only have information for the Cook County deaths. And of the 5 deaths that happened under the age of 20, you'll see that 2 of them, I'm marking here, had coronavirus as the primary cause. 2 of them had some other problem, and then one of them looks like it was just pure coronavirus. And so you'll see is that it's not the healthy under 20, normal under 20 healthy people that are subject to risk. It's those that have some kind of compromised immune system. So these are important things to take into account when we talk about school reopenings. So let's move there. So the exact opposite, I will give you facts now about the exact opposite, or the opposite extreme. Whereas the elderly are at biggest risk, you'll see that the youngest are at almost infinitesimal risk of death. Looked at it this way, this is the CDC's numbers. 1 out of 34,000 from ages 0 to 19, if they get infected, they'll die. So that's 0.003%. Or said the other way, the survival probability is 99.997. Our kids are safe. It's much riskier for them to suffer from the flu or some other kind of disease than this. And the good news is for teachers, 1 out of 5,000 for ages 20 to 49. So if they get infected, just 1 in 5,000 will die, or has a probability of death. That's 0.02%, or said the other way, 99.98% probability of survival. This is really good news for our kids and for our teachers, especially those that have no comorbidities. And this is something that I wish the school included as part of its metrics. I think the next chart's actually more interesting in that this is the actual deaths reported by IDPH, the Illinois Department of Health, and the number of cases reported. And so if you just take the number of deaths divided by the number of reported cases, you get the case fatality rate in Illinois. These numbers then, of course, are the actual numbers in this state. And you won't see these numbers used by the school district. And I don't know why, because I think they're very important. They're very important to understand what the risks are for the individual age groups. The good news is, as I mentioned, for school age children, there's only been 8 deaths out of 80,000 cases. I think we're all actually, this is as of the November 15th, we're actually closer to 100,000 cases now. So this case survivability rate is now, getting closer and closer to 100%. And the good news for teachers, 20 to 49, we did it down here as a bucket. This is as of November 15th. It's a little bit better now. 524 deaths out of nearly 300,000 cases, reported cases. And so the situation looks very good. The good news is also is that 2/3 of our teachers are under the age of 50. And so to the extent that they don't have any pre-existing conditions, and some of course will, we know that, but to the extent that they don't, they should feel very comfortable about being in the classroom. And same for the 50 to 54-year-olds. Of course, you've just got to manage that pre-existing condition risk and be aware of it. Now, all that I've said about the problems of the elderly as being one of the problems, another is the relative low probability of risk for the young, and the comorbidities as another risk factor. The good news is that New Trier is spending $1.3 million to test and screen. And so that, on top of everything else, from our perspective, should be that the school can afford to take more people in the school because they have greater precautions. This is the last week that has been made public by the school district of the testing results. And you'll see here every day from the 16th of November to the 21st, there were nine students who tested positive. They never made it into the school because you provide the spit results beforehand. And so if you're positive, then you don't even make it to the school. You actually go and get tested again for proper testing to make sure that you're positive. And the good news is if you look at the staff, none of them have tested positive. And the overall positivity rate has been 0.41%. That's a very good rate. And again, remember, this is the positivity rate, but these people never made it into the classroom. So by having this testing system in which, I don't have the numbers right here, 88% of I think kids have signed up and are being tested, and 70-something% of staff, the more that we get closer to 100%, the more that on top of the social distancing and masking and protections we've given teachers with the partitions and all that, the more that there's less and less reason not to be open unless we have a problem in the school, because we're controlling it from the outside. So that's another piece of good news as to why schools can be open. Another one that the school board has made clear is that we're nowhere near the capacity we think we are in terms of kids being in the classroom. I've circled in red here the overall attendance, even though we're supposed to be at 25% attendance. The reality is that the school overall is somewhere between 17.5% full, and we're just like almost 19%. So the reality is we're not even getting close to our 25%. And there's this talk of there's a push by many of us to double our participation in the school, and most people believe that would take us to 50%, but it's not true. Even if we double or this dual track, it might take us to 35%. So we're nowhere near running a high capacity in the school. And so therefore, especially if you open up gyms and use all the other areas for teaching, there's no reason why we can't increase the attendance in the schools and still be within the limits that the administration feels comfortable with. So it's just it's a sad thing that we're only at 17.5% of the people instead of 25%. But by the same token, for those of us who want an option to be in school, it opens up the door. And let me be clear about one thing. When we talk about wanting more people in the classroom, we're talking about the people that want to be there, who want that option. We're very supportive of the online portion of it because we need to protect those those kids, families who don't feel like they can take the risk, can't afford the risk, or have underlying conditions. They should continue to have that option. What we're looking for is to have a broader in-class option for those of us who don't have the underlying risks at home and who feel more comfortable with the overall risk. Um, just I think this is going to be one more important fact. We know that some teachers have had accommodations because of risks they feel they can't take. Some for healthcare, others for daycare. We FOIA'd recently New Trier to find out there's a great policy, very favorable for teachers, that provides sick leave accommodations to teachers. And basically, a teacher who comes to New Trier starts out with 180 sick leave days that they can use over their career. And each year, they accumulate 14 more. And they can accumulate those unused sick leave days throughout their whole career, up to 2 years worth, which can be used at the end of their career to turn in as 2 years of service. So they can have this unused sick leave, they turn it in as 2 years of service. Well, this is a moment perhaps where the sick leave becomes very valuable, where those teachers who can't afford to be in the classroom could be using this sick leave and then allowing the district to hire certified substitute teachers to take their place until the situation corrects itself. You have 214 teachers that have 300 to 360 accumulated unused sick leave days. Another 135 that have anywhere from 200 to 300. So there's a lot of sick leave days that teachers could be using if they can't make it to the classroom. One of the things that those of us who want in-person teaching want is we want teachers in the classroom. We want a teacher in every classroom. Kids have expressed a lot of dissatisfaction with going into a classroom, sitting there with their headphones on and watching their teacher while they're in class, watching their teacher who's not in the classroom. So this sick leave is something that I think should be discussed by the board with the union as a way to alleviate some of the problems at the school district. And last few things, as we've talked, people have tried to politicize this problem of opening the schools, but it's not a right or a left, Democrat, Republican. I think you find parents in the New Trier district on both sides of the aisle who just want their kids in school because everybody knows that that's the best. If you have the flexibility and the ability to take the risk because you don't have underlying causes, everybody knows that in person is the best way to approach education. And we're seeing this from the CDC. Robert Redfield, he said he supports face-to-face learning in schools. UNICEF has come out with I encourage you to read that link there. They wrote many things about how we've got to open up schools and open them more. The New York Times editorial board says, they were saying close bars, close anything, but don't close schools. And CPS, who we know is struggling, and their kids are struggling. Most of their kids are struggling because the learning gaps are getting bigger. Parents are struggling because they can't work. It's a real mess for CPS. But they're announcing that they want to start in January. So you're seeing both sides of the aisle say, open up schools and open them more. And I think that, those of us that want to see more in-person learning are just part of that voice. And my last slide is just one of the things that we think is totally forgotten. And if you were to look at the reopening advisory board's metrics at New Trier, you'll see lots of metrics about COVID, lots of metrics, and lots of discussions about COVID. But what I haven't seen are any metrics on what's happening to the kids who aren't in school. What are the metrics there? What are the health metrics on mental health, anxiety? If you were to think about other schools, there's a risk of kids being at home all the time, so they can be subject to domestic abuse. You've got risk in suicides. You've got misdiagnoses of healthcare. You got all kinds of problems, and they're being captured more and more by groups who are just laying it out. You've got the one group, Wellbeing Trust, that talks about they estimated 75,000 additional deaths, not because of COVID, but because of the livelihood problems of COVID that they create. And I think they've expanded to 150,000, if I remember reading correctly. So these risks are huge, and nobody seems to talk about those. And they're particularly bad for the minority kids who are being pushed more into poverty. Their earning potential is dropping as they miss a whole year of school. Their learning gaps are getting worse. A lot of them depend on schools for food. It's a real disaster for the lower income kids. And so I think that that the discussion needs to continue to evolve and mature, I would say, to include all the data, all the science that comes from not just the COVID side, which is also one disaster, but there's the other disaster of business lockdowns and school lockdowns, and they're both creating disasters. And our science and data should really include both if we really care about the whole, not just the part. So with that, I'm going to end it there, and open for questions. And thank you guys for joining, and shoot away at questions.
Yeah, great, Ted. Thanks. We do have a few questions, and I did want, I appreciate so much all Ted's hard work, and synthesizing all that data is incredible. And remembering that you have to look at the data and see where the risk groups are, and reiterating Ted's point that, when we practice medicine, every intervention's got pluses and minuses, and we make decisions looking at all of that. And so to just look at one side of the coin at this point, isn't how we practice medicine. Like I said, the medical center's open. We're seeing a lot of things, but we have to address managing COVID as looking at the risks and benefits of all our interventions. So let me go through here. There's a few questions. Someone asked, I think Ted, you might be able to shed some light on this perhaps. Says the teachers state safety is their concern. Do we know what specifically the union's objective is?
Well, the objection. So I've come to understand that there's, of course, there's a collective bargaining agreement between the school district, and the teachers union, and in there, there's nothing precise in that collective bargaining agreement about COVID. And so my understanding is that they've reached some kind of memorandum of understanding of additional things that the union wants the administration to do. And of course, that revolves around enhanced PPE, making sure there's enough safety protocols. We FOIA'd for that memo. We have not received it yet, so I can't tell you what precisely they want. But we'll share that once we've gotten it. But I do know that they're concerned about the PPE. It's hard for me to understand. I understand why people are scared. I mean, there's no doubt in my mind when you see the number of deaths, and you see the number of cases and the hospitalizations, and you see what's happening on the TVs. It's easy to understand why people have fear. My big concern is that I don't think that the reopening advisory board, they call it the RAB, I don't think that the press, I don't think enough of them look at the cold hard facts enough to kind of dimension properly the risk. Because if you look at it in the numbers we just saw, and these aren't my numbers, these are the numbers from IDPH and CDC. The numbers for our kids, people who are worried about their kids, unless their kids have an underlying cause, the numbers say they shouldn't be worried at all. And those younger teachers who are healthy shouldn't be worried. But it's not clear to me what they're concerned about at all. And I think they should do a better job of that. And I think the board. I think it's on the board to actually make sure that it's clear why, because we as parents should understand exactly what it is that they're worried about, and the board should be using data to make their justification. And so far, given the controls they have, given the statistics that we've seen, the board hasn't made a case for why they should be not opening more.
Yeah, and I'd also add that just evolving with the data, and these advisory boards, set up early on. I think you have to evolve and make sure you're including people who are actually working with COVID patients, working on the front lines, because again, our experience is really that this is being managed, and we need to protect the most vulnerable, but that these younger age groups without comorbidities, it's really background noise, background issues. We deal with everything still, and there's a lot of other serious issues that kids and younger people face. Let's see, another question. Someone wrote, "Thank you so much for sharing all this great information and for what you do for your patients every day. Would you please share with us what the protocol is for students who present in the ER with mental health concerns?" Yeah, so from the mental health standpoint, just in general, folks are evaluated whether they meet criteria to be admitted to a psychiatric hospital, or whether they can go home with resources and follow up. And so that obviously depends on their chief complaint, whether they're suicidal or want to harm other people or have some decompensated condition, mental health condition that's preventing them from functioning. We do have our mental health workers in there in person. And for Medicaid patients, they have folks that come to the ER as well to determine whether someone needs to be admitted. If they don't, then it just is a matter of following up with the proper resources. There is quite a bit of telemedicine going on, which is one of the positives that has come out of this situation. That whole service line has been accelerated. So yeah, there is a lot. There's also a lot of substance abuse that's increased, with the pandemic, related to anxiety, depression, and then series of people trying to cope and using drugs to do that. So we're seeing a lot of that as well, and we address the acute medical issue and then try and connect people to resources afterwards. But it's definitely a big problem, and they're coming right to the ER. So the next question. New Trier High School states that beginning 11/6, IDPH began including quote unquote probable cases in their totals. To what degree are the charts you are showing with a huge November spike reflecting probable cases versus actual cases? So I'll throw that to Ted.
Yeah, so Sharon, that's a good question, and we're always struggling with state data. We argue that we're in one of the states that gives some of the least data, and they don't help us do our analysis. So we always have to kind of dig around and try to find things. We've actually been very fortunate. At WirePoints, we started reporting their data, but graphing it differently, cutting it differently, taking the same data and cutting it differently. As I mentioned, those comorbidity data, the state won't publish any of it. Cook County has that data in one of their files. We go out and get it and cut the numbers and just put them out and make them public. So people appreciate that. But I think it's fascinating. You're asking one really good question. They added probable cases, and yet they weren't breaking out the data between probable and the ones that they felt were actual. And so we were left to report what they give us, and it makes us weak in reporting what we do. So we're only as good as the numbers they publish, unless the CDC or somebody else has some specific numbers. So no, we don't have a way of adjusting for that, and we know it's a risk we have, or it's a weakness we have, because we're just using the government data, and that's the best we have.
Yeah, and I'll just add a little bit to that. In my training in medical toxicology, where I had some exposure to some of these surveillance reporting systems for various other things. What they're doing is they basically data mine what doctors put down as a chief complaint, or as a final diagnosis. And sometimes we don't know if someone has COVID, so we might write COVID-like illness, or we might write they have a list of keywords they're data mining, so it could even just be cough. And so you raise an excellent point that gets thrown into their surveillance system is quote unquote COVID-like illness, but it may not end up being COVID. So the data can be messy. On the other hand, I've encountered patients who've been tested for COVID 20 times and may have had 20 negatives. And so is that all going into the negative bucket? Or on the other hand, when patients get admitted to the hospital, they get tested, and to get released to, for example, a nursing home, they have to have several additional tests. So how many tests are representing a single person or a single episode in the hospital? It's all of that granular data just isn't reported. So let's see, another question. Now that the saliva tests are in place, To what degree can we expect slash demand that the daily screening questions by the school be revised to reflect the Illinois Department of Health standards around travel to other states, et cetera? For example, travel to orange states, quarantine 14 days, or negative test result, which the saliva test provides. So, Ted, I don't know if you want to start with
Yeah,
your thoughts on that. Yeah.
I don't know the answer to that. We've had, I've been to the last 3 board meetings, and a couple of them have focused, heavily on the quality of those saliva tests. And, I've heard some pretty good responses about the strength and the quality of those saliva tests. They're not meant to be um, the test, because if you are positive on that test, they still send you to go get tested again to get the true test. But I think they feel very good about it catching people who are positive. And so I'm not sure the answer to your question. However, you bring up a question that I've raised, and will be raising with the board, and that's, if you have those tests, if we as taxpayers are spending 1.3 million for those tests, then those tests should start to supersede a lot of the metrics that are required for at the school. Because if our kids can provide that test, my wife dropped off, I think, a test just now for my son. If those tests can be used, then we should be able to do much more. And of course, with all the other protocol, we're not saying that we should get rid of all the other protocol. What we're just saying is that with the strength of the saliva test, we'd like to think that some of the other metrics we're using today are I don't want to say worthless, but some of the metrics about what's happening in the zip codes in other communities, well, we know what's exactly happening in our school. So we think it should be very positive, and for that reason, we think that there's no reason why we don't have more kids in our school.
Yeah, and I would just add on again, just a theme about sort of evolving the strategy, evolving with the knowledge, and then just not making things too overly cumbersome, because again, that's not what we do in the hospital. Like I said, I've never been tested, and I've been working for 20 years, but working in the pandemic since the beginning, because it's the first step in the thinking is that, is this an essential business? Does this need to be open? And then we know with masking, with me wearing a mask and doing what I need to do, I'm not going to, it's not high risk to just be at work. And so there isn't just this widespread transmission going on. And I think that the schools just need to, they shouldn't be more restrictive than what medical centers are doing, who interact with a broad population of undifferentiated patients, which is what happens to me when I go to work. And it should, if they're putting this testing strategy in, which Ted said, and showing the data, then you need to be nimble and call out the things that don't factor in anymore in your decision making. That's how medicine's practiced. And I think we all need to realize that basically, the board, they are in a tough position, because they're basically being asked to practice medicine and manage a large workforce. And if they're going to, they've been put in that position, they need to refocus on having folks with the expertise to be living with the virus and the pandemic, and switching their strategy, to sort of what this question is getting at. You can't just have all the different parts you were using that really aren't needed anymore if you're doing the testing. So I concur with that. And also, it's just very confused. It's very, very hard to kind of weed your way through all these different guidelines. And a lot of them are self-referential back to like the CDC, which then says, do this, except if your local health department wants to do something different. And then they refer back to the CDC. So again, I think we're in a phase where there's enough data around the risk groups, and how there's enough data to know how to keep people protected as what we do in the hospital, to say that it's safe to be in school. It's safe for teachers to be at the front of the class wearing a mask. If they want to wear a face shield, that's fine. And we paid for the screening, let's use that and, move forward. So, and I'm not sure if anyone wanted to add any other questions, or Ted, if you
Yeah.
wanted to give any kind of closing remarks.
Well, there's a couple more questions, and I think they're really actually
Oh,
two really
okay,
really good ones.
okay.
One of them is we often hear about the concern that kids will catch it at school and then bring the virus home. What's the risk of that? And I've spent a lot of time recently trying to figure that out because there's been a lot of research done. There's always a concern that schools would be a super spreader, right? You bring all these kids together and put them in one room and, well, in a whole bunch of rooms, and that they would be spreading it around. And what they're finding is that the schools aren't super spreaders. And that's particularly true for the young kids. They're not catching it at school and spreading it in school. Often they're finding that the kids, kids, especially the older kids, are catching it at parties or get-togethers at the beach or whatever it is, but not in school. And so you're starting to hear many of the public policy specialists at the national level, international level, start to say that probably the safest place for kids is at school because they're in an environment that's controlled. Many of them know they're going to be tested. For example, in Nutria, if they know they're going to be tested every day before they go to school, then they're more careful. And so what we're seeing is that the schools aren't the super spreaders, and we should actually feel a little bit more comfortable when they are in school because they're in a controlled environment rather than hanging out with each other in basements or whatever. So I think that's a key point, and I think the more and more we get comfortable with that, it's another reason why schools are getting more comfortable being open. Those comments are coming from UNICEF, they're coming from Fauci, they're coming from all over the place. The second important question that we got here was this reopening advisory board. This is a critical question because, as we know, most things these days are heavily politicized, sadly. And a reopening advisory board, who's on that re-advisory board can make a big difference because we know that there's doctors and epidemiologists who can be on the left side of this issue, the right side of this issue, and so who gets to name them matters. And what's not clear is, for example, at a place like Nutria, how is that reopening advisory board chosen? Another good question is which board members, for example, are on that reopening advisory board. I think only one board member's on it. And you have to ask the question, do you have the right representation on the board to make sure that all sides of the data make it into what's debated? And if not, then you'll find metrics that, for example, might be too strict on opening, or you could go to the other extreme. It might be to open too fast. Right now, I think what we've got is a situation where they've been much more, Nutria has been much more cautious about opening, which is why our kids have been in school so few days. So I think it's a big question we'll be asking the board, precisely how do they choose how that reopening advisory board is selected, then which board members are on it, why aren't more board members on it, how are the decisions being made, and a very important thing is, are there discussions made public? Because that's the big debate about how to keep the school open, how much to open it, whether to close it. That stuff should be public, and all of our school officials should be on the record for what their positions are, and taxpayers and family members and parents should know how those decisions are being made. So it's a critical thing we'll be asking the board.
Yeah, and just to add on, there is a large multi-center study going on now of emergency departments and trying to document transmission in emergency departments between staff as well as like amongst patients. But just empirically, there really has been no clear documentation of transmission, be amongst emergency department staff. Again, we're wearing, an N95 mask or if we're going in a COVID room, or a surgical mask otherwise. So, I mean, again, I think looking at, some sectors of our society where we are in very close quarters working, I think it should be reassuring to people that there really isn't transmission going on amongst staff if you're doing the proper things you're supposed to do. So,
We've
um,
got another question,
okay,
Carrie. So Dr. Fauci, and I saw the short video clip.
yeah.
Dr. Fauci this morning said, close the bars and keep schools open. And I think that the question is, why is it that those working in these industries want to do the opposite? Why don't the school people want to open? And somebody recommended that we actually should just hold schools in bars, right? So that might solve the problem. No, the question is we got an incentive problem, and somehow the teachers unions have managed to gain a certain amount of power and sway over the board in a way that parents haven't. And a lot of that has to do with the organization of the teachers unions. They've been given certain rights, collective bargaining rights by lawmakers that give them a lot of power, whereas parents, we seemingly don't seem to have that kind of power. We of course fund the schools, we pay the taxes to fund the schools and the teachers, but we're not organized in a certain respect. And that's why what we do at WirePoints, what Open Nutria has been doing, of course, what Nutria Neighbors does, we're all groups who try to advocate on behalf of parents. But I'd argue that to the question that was given here, the laws give way too much power to the teachers unions at the expense of ordinary residents, and over time there's too many incentives built up to give them too much power, and I think those need to be changed over time.
Yeah, well, I think what you mentioned, Ted Foying, some of what their specific requests are, would be really helpful and help with transparency and understanding, how to move forward. There's another question here about any information from any data or sort of progress updates about just our Catholic school sectors who, started out were open, and do we have any, do they release any data about, positive cases, and do we have an idea of how things are going for them?
Well, so we know a good bit of stuff about other schools. Of course, it makes us have to do a little bit of work to figure out what's going on. But just recently in the press, it was announced that a few Catholic schools were going to shut down for a little bit because of COVID, but the overwhelming majority will stay open. And I'm talking about the Catholic. I'm talking about the Chicago Archdiocese. The majority are staying open, and they've been open, and they're open 5 days a week. You've got Loyola nearby, which of course is not one of the Catholic schools, but they've been open up at 50%. You've had some other school districts shut down. But what you can say is that many schools have opened, have stayed open. They stuck with it. Sometimes they take a pod. If somebody in a pod gets infected, they shut down that pod, but they keep the school open. Sears, which is one of the feeders of Nutria, has had its schools open the entire time, pretty much all day from 8 to whatever it is, 1:30 or something. They close before lunch. But they're in school every single day. And what I do know is that on certain times, a couple grades have been shut down, but the school stays open. And so I think that's really smart. They try to manage the risk, but not shut down the whole thing. And that's the way it should be. You should use your data. You should know who's been infected, where it is, do you have it under control, and then act accordingly. And I know all the Catholic schools are doing that as well. But I think it tells us a lot that this is not a school risk. It's if private schools can stay open, if our feeder schools can stay open, then there's something else going on, sadly. And I think it just has to do with there's been too much fear. I don't think the board has been strong enough in saying we want our schools open. We're going to keep them open. We're going to use our metrics, be smart about our metrics, manage our risk. I think they've done a great job of managing risk. What they're not doing is a good enough job of keeping it open and just keeping it going. And I think they just need to be a little bit stronger and braver.
Great. I think we got through all the questions, Ted. I know we just have a couple more minutes here. I think we got through everything, but I just wanted to thank all our community that follows us through our newsletter, and just follows the things we're doing, and then additional efforts that Ted is doing, helping sort of focus on Open New Trier and all of that. And we're excited for the new year coming with Open New Trier, with New Trier Neighbors and Open New Trier, and just try to work with our community, just to educate and inform. And I think for me, just I want people to read broadly. I think this has gotten very politicized. It's very bizarre to see like my medical world completely politicized and kind of taking a lot of things out of context. So I'd say, read broadly, talk to a lot of people, stay informed. And we deeply appreciate everyone, following us. And we wish everyone a healthy holiday season and healthy new year. And Ted, I don't know, you want to say anything?
Sure. I think just as we're talking about opening schools, I think we lost a lot of opportunity when we didn't open our schools on time as was originally planned. And we supported the school board's plan to originally open. And then we lost more ground when we shut down again. We're only open for a week and then we shut down again. We've lost ground, and what we need is strong leadership from the board. And we want them to know that at Open New Trier, as we've gathered over 500 parents, we support the board in opening more. I know that New Trier Neighbors, as a separate group, is very supportive of getting those schools open. And so make your voice heard on December 1st, which is Tuesday. Is that right?
Yep.
There's a board meeting from 6 to 8, again, to discuss this reopening. And the discussion is how quickly to move from 25% to 50%. And as I mentioned earlier, 50% is not 50%. It's only about maybe 35, max 40%. There's capacity there. We've got the testing, we've got all the good things, and we've got really good metrics. Now we just need good leadership from the board. And show your support, be strong as parents, write an email to the board, tell them what you think, or show up at the meeting and make your comments about what you'd like to see. So thank you guys for joining. Please share our comments here. We've recorded this, we'll post it, and please share around as you can. And thank you.
Yeah, and just reiterate, so December 1st, 6 to 8, it's in person, but they also have it online. And if you do want to submit a comment, there is a time cutoff, a comment for the board to read, or if you want to show up to read, there's a cutoff for submission. So look, I can't remember, it's like 2:30 or 3. So look on the website, but it does make an impact to also just write an email to the board, obviously in a respectful manner, just reiterating, feelings about wanting it to be reopened safely. Ted's at wirepoints.org, he's got a lot of these articles with the data and charts as well, if you want to kind of review that again. So with that, I think we'll sign off. 1 minute short here, and we appreciate everyone, and we wish you a healthy holiday season.
Thank you guys.
Bye. Okay.
Bye.